Good morning, everyone, or rather, sorry, good afternoon, and hello to everyone that's joined. So welcome to this webinar on accelerating the coverage and capacity of UCR services to deal with falls. So we want to thank every single person that's joined on today, no doubt, at least partly in response to the letter that was sent out last Monday by the NHS. So just some quick introductions initially. So my name is Sam Webber and I work at Felgains with Falls Lifting Equipment. Grant, would you like to introduce yourself?
Yeah, with pleasure. So I'm Grant Woodcock, again, work at Felgains and work primarily with response services and anyone dealing with falls in connection with the Raizer chair.
Thank you, Grant. Kathryn, would you like to introduce yourself?
Hi, I'm Kathryn James. I'm Clinical Pathways Manager, work for the Yorkshire Ambulance Service, and I also work in a national role for the Association of Ambulance Chief Executives.
Very good, thank you, Kathryn. And it looks like Amy, who is also a panelist on the call, will hopefully rejoin. It appears as if she's just dropped out, so we'll come back to Amy in just a minute. So some brief housekeeping points. The webinar will be approximately an hour. We would really encourage questions, which should be submitted via the Q&A box, not the chat box. And we will then run through as many of those questions at the end. Please note the chat box is actually disabled. There will be a recording available and the slides, excuse me, can be shared after the presentation. So a quick question as to why we've put together the webinar. Urgent community response is not a new concept, obviously, and we really don't want to be teaching you how to suck eggs this morning, but we thought it would be useful to share some best practice and insights. So we will be hearing first from Kathryn with a presentation, and then as long as Amy has got her internet sorted, she will be following shortly afterwards. Following that, Grant will be presenting the Raizer 2 lifting chair as currently being used in falls response. And then after that, we'll be running through the questions that have come in throughout the webinar. So Kathryn, I would like to hand over to you, please.
Thank you very much. I think my slides are going to come up shortly, but just a bit of background. I've been a paramedic and working in ambulance services for the last 40 years. I've been doing a lot of work locally and nationally around falls. And paramedic background. Next slide, please. So first of all, I think I mentioned I work for Yorkshire Ambulance Service, but I also work nationally for the Association of Ambulance Chief Execs. The logo's there. I have a clinical support role, and I have led on quite a bit of work around falls. And if you've not seen it, it's really worth a read. The link at the bottom there to the ACE Falls Response Governance Framework for NHS Ambulance Services. The headline really about this document is it recognises that there needs to be a system-wide approach to falls, which I think it's great that we've moved on now to talk about UCR teams attending falls. And it's all very new because we know that UCR teams are in development. But to me, this is just yet another option to work as a system to respond to falls. And we're going to describe and talk about some of that. And it's all around falls prevention. There's quite a lot in the framework, but there's quite a lot of detail in the framework about how we can work together, how different services can integrate from prevention right through to the person that's on the floor. And obviously that's, I think, the focus of a lot of this webinar today is, how do we respond to the person on the floor as a system using the new and developing UCR teams. I'm going to describe some of the examples of development that's ongoing. And Amy's going to describe down in Dorset the models. I'll talk about some models that we've been developing and are still developing in Yorkshire Ambulance Service. So the next slide in a minute is going to be for us all to watch a 3.5-minute video, a little film that we made in Yorkshire Ambulance Service, and it just gives an overall picture, but particularly emphasises on how we've been working with partners. This is before we started working with UCR teams, but it does link together because this, I can't emphasise enough, it's the system response to falls. What we're trying to push back on, and we know that the ambulance services now are so stretched, that the scenarios are, well, the real things happening day to day is that, and probably all know this, that patients are waiting on the floor, sometimes for hours, and they are coming to harm. So if we don't respond as a system and just expect an ambulance to roll up 12 hours later, we're going to cause harm. That patient's going to end up in hospital. And we're all about the same thing. It's keeping people safe. The priority should be get them off the floor. It doesn't matter in my view, who attends that person on the floor. It's about getting someone that's appropriately trained with the appropriate lifting kit so that they can get them off the floor, and then all the mop up and follow up, whether that's a clinical need or a prevention need, that can all be worked out with whatever community services are going to get involved with that patient. So I'm just going to pause, and this film is 3.5 minutes long. Thanks, Ruben.
At Yorkshire Ambulance Service, we receive around 2,000 calls into our 999 service every day. And more than 1 in 10 of these calls are for people who have fallen. Falls can cause serious injuries to patients, and it is right that a prompt response from the ambulance service is received in these cases and the patient is taken to hospital. But there are many calls that we receive where the patient is uninjured and just needs assistance to get back up off the floor. The way our service works means that codes coming into the 999 service are coded by priority of symptoms so that the most life-threatening emergencies and urgent care needs are dealt with first. This means that in periods of high demand, patients who have fallen but have not injured themselves may be waiting an extended period of time for a response from the service. For a number of years we've been working with partner providers across Yorkshire to try and offer an alternative response. The staff working in the Falls Alternative Responding Teams have links into the clinical hub within the Emergency Operations Centre here at Yorkshire Ambulance Service. This is to ensure that the patient is dealt with in a safe clinical manner. We now have 11 partnership agreements with various teams across the Yorkshire region. These are clinical teams, non-clinical teams, fire rescue service support staff, and our existing community responders. We hope to partner with more of these services across the Yorkshire region so that when demand is high, we have the resilience and the partners to work with and refer to help get uninjured patients up off the floor.
Here at the Community Resilience Desk, it's my responsibility to look at every 999 call that comes through for fallen patients, to look at if we've got a responder team on duty, and if they are on duty, to allocate the details to them and send them all the details down about the patient. Sometimes we do still have to send an ambulance if the patient is poorly or injured in any way, but quite often we don't need to send an ambulance if they just need help off the floor and they are uninjured. The more responders that we have available, the better this is for our patients, because they will receive a more prompt response and ambulances can then be saved for more serious life-threatening emergencies.
Hi, my name is Erin and I'm a Community First Responder. I joined the Community First Responder scheme through my medical school. I'm a second year at Hull York Medical School, and in my first year I joined the pre-hospital care programme, which enabled us to become part of the Community First Responder scheme. Normally during the year we respond to the typical life-threatening incidents such as cardiac arrest, heart problems, chest pain, difficulty breathing and things like that. However, once COVID started to worsen, we were able to get some extra training from Yorkshire Ambulance Service, which enabled us to form a falls team. So as part of the falls team, what we do is we respond to non-injury falls. So this is your typical, someone's fallen over, they're not injured in any way, no obvious injury, but they're just struggling to get back up. So what we do is we go in, we've been able to get loads of extra kit, such as the Raizer chair, which lifts the patient off the floor without them having to put any extra work in, and it's very easy to assemble around them as well. And yeah, so we essentially do their observations, get them off the floor and into their usual comfy position, whether that's back on a bed, into a chair, whatever's comfiest for them.
Hi, my name is Hayden. I'm a second year medical student at Hull York Medical School and a community first responder with the Yorkshire Ambulance Service. I think falls training as a community first responder is really beneficial because it means that ambulances don't have to go to certain incidents where they're not needed, and also patients can get up off the floor quicker. While we're at jobs with patients, we have constant contact with clinicians to make sure that the patients are as safe as possible before and after lifting them up off the floor.
Hello, I'm Julie. I work for Sheffield Citywide Care Alarms. We attend falls. It can be very distressing for someone that's on the floor. We work alongside Yaz. We can ring them up for advice.
I'm Eileen. I work for Sheffield City Council. I'm part of the Citywide Care Alarm team. We also work in conjunction with Yaz, and we go out to people that press the emergency buttons and need help.
Thank you. So that really described quite a range of responses to falls. So from volunteers to urgent clinical teams, they weren't particularly showcased because that's still in development, and quite a lot of the alternative responders that were described there. The work now that we're developing in Yorkshire Ambulance Service around the UCR is we're part of the 100-day NHS England Challenge, looking at what's called the push and pull models. So this is whether we push out jobs from the ambulance control room into UCR, or whether the UCR pulls the jobs in themselves by having access to the CAD, the actual stack of emergency calls that are constantly coming in. What we're calling it now in Yorkshire is we got a bit fed up of that many single points of access, because there's so many of them. So we're now calling it a one-stop shop model. So for our frontline clinicians to be able to ring one number in one patch that does what it says on the tin, it's a one-stop shop. And by ringing that, you can speak to a clinician for our senior advice and guidance. So our clinicians don't always fully appreciate what a UCR team can do and provide, and how the UCR teams can link to other services. So actually being able to ring and say, I wonder if this patient is suitable for UCR, and the clinician can make that decision whether to accept that patient or not. So we're calling it a no wrong door ethos, that, one phone call can sort it out, that the services are coordinated and it avoids multiple handoffs. So currently we have just started passing some what we call category 3 and 4, the urgent 909 calls, through to UCR teams, and we're in pilot stage in one area. Thanks, Ruben. What's really important to consider for the UCR teams is you need a community provider alliance sitting behind the UCR team to make sure you've got a no wrong door ethos, because these patients have just not got one thing wrong with them. They're multidisciplinary conditions, social aspects, medical aspects, prescribing aspects, therapy aspects, and that patient needs that full wraparound service to make sure they can remain at home. We are aiming even wider for a regional number, just to make it as simple as possible, because the amount of pathways that we've developed now for our clinicians is just so complex. We've got all the pathways where we're taking the patient to hospital, such as the development of frailty pathways, development of direct admissions to acute medical and surgical wards, and the frailty services as well. But actually for the community, one-stop shop, one regional number will really work. You won't get that clinician who's really fed up with having to ring one number, then be said, oh, it's not our team, you need to ring another number. It's just delaying our crews on scene, and we need to be able to come clear and obviously to respond to the next emergency. So there's a need for that massive integration of community services that I know probably a lot of you are currently working on. In relation to workforce, and especially a lot of workforce going off with Omicron COVID at the moment, it's about really considering sharing the workforce. And if you've not already had a look at looking at rotational models, so a lot of ambulance services will have specialist paramedics or advanced paramedics, and we've done quite a lot of work of looking how we can rotate them and actually work them within the UCR and community services, and then back into the ambulance service, and truly integrating those models of sharing resources. What we're very wary about is losing our paramedics to UCR teams, to primary care. It is happening, and it's really difficult. It's no good pinching each other's staff. We've just got to work together, because the workforce is rather stretched, as you all know. Thanks, Ruben. So this is just a picture describing what we see at Yorkshire Ambulance Service as our one-stop shop model. And it is a bit of new terminology, but we just, like I said, the single point just became a bit bored with the fact that there was so many. So the 999 caller 111 comes in, as you can see there on the left, gets an that EOC stands for Emergency Ops Centre, IUC, Integrated Urgent Care, triage. Can then obviously might need an ambulance at that point, or might need to go into your local cars. But the ambulance clinicians need to access, in the middle there in yellow, is the one-stop shop to ask for advice, to have really good clinical discussions and conversations, to be able to signpost patients and refer, ideally 24/7. And we know a lot of the UCR teams may only be open limited hours at the moment. But for us as an ambulance service, 24 hours is obviously how we work, how our patients come in into our services 24/7. So, you know, as 24 hours as you can, it's going to be really helpful. And you can see there on the right, the various services, there's so many of them, that for one patient, they might need a myriad of those services. You know, a frail elderly patient with multi-comorbidities might need a range of those services to be able to provide that care at home. So hopefully that just describes the various services that need to be integrated with the UCR there at the top. And you can see the UCR top right there. I'm really, really keen that all the UCR services, hopefully that's why you're here today, are really looking at how you can respond to falls and really looking at how you can work with your ambulance service to do this push or pull models. And I think Amy's definitely, she's back on the call, she's going to, she's out there in the community today actually responding to falls and really sorting that patient out earlier and saving those ambulances that can be delayed. Next slide, Ruben. Just to give a mention, because there might be some people on this call from the care home and domiciliary care provider perspective, and back to the governance framework I mentioned on my first slide, it's really important that we support all our staff in care homes and domi care providers, because they need support to make sure that their policies, procedures and training is adequate to be able to manage falls. They come across in care homes many falls, and in domi care, you know, the morning visit can often end up finding the person on the floor. We've said in our governance framework that it's quite unacceptable to call an emergency ambulance just to lift someone up. And I know a fall is complex, it's not always just a lift. We've got to be very careful about exploring the cause of the fall, the medical reason for the fall, and obviously if there are any injuries. But blanket no lift policies, we believe, are unacceptable. And ambulance services have done work, quite a lot of work, you know, to try and get that message across. And there are some really good examples of where ambulance services have been involved in training and education and supporting staff in care homes, and obviously giving them advice about the need for equipment. And then the UCR development is obviously care homes can start to access UCR direct. I believe that's starting to happen. And giving care homes, enabling them and empowering them to say they don't have to just ring ambulance for certain patients and certain conditions, particularly if good care plans are in place, they may be able to have direct access into UCR. Next slide, please. Back to the letter that Sam mentioned at the beginning, this was sent out from NHS England on the 30th of December and went out to all. I particularly liked the fact that this paragraph was included around working with local councils and providers of telecare. So as described in the little film that we played, the partners that we're working with across Yorkshire include a lot of local authority telecare services. So where they already have existing 24 responders, we're finding this fantastic that we can partner with them and ask them to attend some of our falls. They can benefit because they can end up with a new customer. So a person who's fallen and hasn't been able to get help because they haven't got a pendant technology Telecare alarm, it's about, again, that system working together, because if someone falls and they can't get help, obviously they're going to be on the floor a long time. So if you've not done this already, have a think about connecting to your local telecare services. They do send a lot of demand, a lot of jobs through to ambulance services, because obviously the older person may press their alarm because they've fallen and are on the floor. They may ask relatives, key holders, neighbours to attend, but often they can't get the person up off the floor. They might not have the kit or the ability to get the person off the floor. So we see a lot of demand coming through to ambulance services. So one of the examples in Yorkshire is that one of the local authorities now that have the 24 responders, they answer the alarm calls, they have been fully integrated now into UCR. So if they get a call for someone that presses the alarm, says they don't feel well or they've fallen, they can ring the UCR team direct, avoiding the ambulance, getting the UCR and the community team in straight away and quicker. So please have a think about exploring, if you've not done already, your local telecare providers, particularly the local authority ones. I think there are over 200 telecare providers out there. If you just do next slide, Ruben. The national providers may be more difficult, and they definitely don't have local responder services. But the local ones, we found quite a lot have retained 24-hour responders that are responding to the uninjured and well fallers. There is a lack of regulation. It's worth it, just understanding the industry a little bit more. But in my national role, we are working with what's called the TSA, the Telecare Services Association, and that is a membership organisation that a lot of the telecare providers are members of, and many of them are working to the new quality standards. If you've not had a look at them, they're all on their website. But generally, telecare alarm monitoring centres answer an alarm, which may be someone that's pressed it to say, hello, help, I'm on the floor, but they don't have any robust triage. They're not regulated by the CQC. They're not clinical organisations. So some of the work that NHS in England are leading on with a new task and finish group is around developing a triage tool so that they can make decisions and potentially, this is the work that's been explored at the moment, potentially go direct to a UCR team for a fall or for someone that's unwell that might need to aim to try and avoid hospital. So if they can ask the right questions as to find out what's wrong when somebody's pressed the alarm, a more appropriate response might be able to be sent. So that's work in progress. Glad we've got Amy back. So I'm going to hand over to Amy now. Like I say, you can see she's sat in a car out and about, and she's going to tell us something fantastic, which is how you started to respond to some ambulance and 111 calls. And I think it's amazing. This is exactly what we described in our governance framework. Working as a system, we can get to these patients that have fallen quicker and manage them at home. So I'll hand over. Thanks, Emma.
Thank you, Catherine. Hi everybody, thanks very much for inviting me today to speak about the urgent community response work we're doing here in Dorset. I'm an occupational therapist by background. I had 17 years in the acute hospital local A&E team, and then very much kind of saw a lot of patients coming in that are older, frailer fallers, and just kind of wondering if we could do things differently to try and prevent those conveyances to hospital. So if we can start the slideshow, I can explain kind of our journey. Next slide. So obviously this, when we've had ED under significant pressures over a long period of time, and then with COVID that increased the amount of pressure and on SWOST, but also our local ambulance service, but also within ED. We did a very small kind of pilot last year during COVID over 12 weeks, which has actually supported and developed this current service model. And over 3 days, we just developed a very quick urgent response car to go and help support 111 and the 999 calls, particularly for fallers and frailer patients, which our population down here is very much kind of an older population. So particularly in the east of our county, the high rates of falls. And obviously this is backed up by the NHS long-term plan and moving that care close to home, and trying to reduce the amount of patients coming and attending ED, and looking at how we could provide that hospital at home approach to patients. And obviously this year we had the NHS mandate to provide a 2-hour urgent community response. It started off for Dorset as a local offer within our local teams, our integrated care teams, which is very much therapy and nursing based. But because of the work we did last year, we very much went straight into the kind of roaming car model to get out and about with 2 clinicians. If you do the next slide. Thank you. To look at how we can provide that, the community teams, looking at our ambulance service, but also our acute hospitals. We looked at the model we did last year, which was kind of looking at 8 till 5 with the consultant nurse and senior OT. What we have now is developed into having ACPs, nurses, paramedics, therapists, and next slide. Oh, thank you. Out of last year's pilot, just a very quick overview, we managed to stop 95% of our patients actually going into hospital. Half of those patients seen were fallers, and 80% of those fallers remained at home. That was providing that kind of holistic kind of team MDT approach, the use of things like the Raizer chairs that to get patients off the floor quickly, responding to the Cat 3 4 calls from the 999 lists, but also through 111. We had really good collaboration across the ambulance service between East Dorset particularly, joining them on scene and allowing them to be able to kind of get off the scene far quicker. But also that kind of joint working and collaboration and kind of shared learning as well. There was an opportunity there. The patients got timely medical and therapy. We had therapy equipment on the car, we had medication on the car, oxygen, and then we were able to kind of give that intervention very quick treatment on scene, and try and reduce that conveyance need to hospital by getting the bloods done and then utilising our services around the community to provide that wraparound service. Next slide. So the summary of our kind of 2-hour response that we're currently doing now under the NHS mandate is the new acute problems such as exacerbation of chronic conditions, serious illness where patients can be managed at home and they're keeping their own wishes with their advanced care plans to remain at home, social care crisis, but also seeing common conditions such as falls, frailty, reduced function, palliative end-of-life care, equipment provision, confusion, delirium. Next slide. So we started a proof of concept following the paper that came out earlier in the year to set up the 2-hour urgent community response. Like I said, we did a soft launch within our local teams, but quickly moved on to the car roaming model to look at how we could do an at-scale model across Dorset by piloting it in one cluster area, which we chose Bournemouth and Christchurch. It was very much an older kind of population. We were providing a vehicle staff with a band 7 advanced nurse practitioner or a paramedic, and a band 6 therapist or nurse or a band 4 therapy assistant that had the kind of same skill set. We've been doing 9 till 5, but lately we've been doing 8 till 6, trying to go across a 7-day service. And it's about reducing unnecessary conveyances to hospital, that rapid use assessment and treatment within the patient's own home. Next slide. The aim of this project is obviously, which is now officially a service launched in November, is reducing the number of ED conveyances. It's supporting our local ambulance service to kind of get to those Cat 3, 4, 999 calls, reducing the 99 dispositions as well from the 111 calls. That's been a massive impact since being part of the 111 team. Improving our pathways to our community services, patient experience, like Kathryn was saying about kind of rotational offers and recruitment and retention across our services, rather than pinching each other's kind of skills, clinicians, is actually how can we work more collaboration and provide joint roles and rotation within our teams. It's improving our links to our MIUs and same-day admission services to try and look at same-day diagnostics. So if they do need to go into hospital, that we're going to a same-day admission service and hopefully then returning home that day. But mainly it's been real huge improvement of management of falls in our community. Next slide. So at the moment we have cars that are based within our integrated care team at 111. I can see we've kind of shoved loads of therapy equipment in, commodes and all sorts. We are looking to getting point of care testing. We need to get medication back on board this time round and oxygen. So it's in its development stage, but we're very much working towards a car that literally is like hospital on wheels. It's that integrated care model, working across all our services. It's looking at that whole person holistic assessment, and following that kind of comprehensive geriatric assessment tools. So not just the physical medical side of things, looking at cognition, social and environment. Next slide. And like I said, the important thing is about the collaboration across all services. So it's not just 11909 and our acute hospitals. We're talking about our primary care teams, third sectors, voluntary sectors, really trying to look at how as a whole service and as a system-wide approach to managing patients, particularly the older, frailer patients, but also there's a lot of work going on with how we're responding to falls. And it's really interesting to listen to Kathryn in regards to kind of the first response teams and how that can link in with the ambulance service, and then UCR directly working with the ambulance service as well. Next slide. Just a bit about the data we're looking at is the number of UCRs that we're completing, the referral source, where they're coming from, the time taken, looking at skill mix, the referral reason and the outcome, and hopefully measured against reducing those ED conveyances and Cat 3-4 calls and dispositions from 111. So that's while we're in our development stage of kind of provide the service, that's the data we're currently collecting, and we're evaluating it at the end of this month, which will be obviously next week. Next slide. Our current data looks about 80% of patients are avoiding hospital admission following a UCR visit. If we're admitting, it's because it's either things like sepsis or fractures needing, or CTs needed, or medical intervention that can only be done within the hospital setting. Our main referrals are now from 111 and 999, and our locality offers are getting those GP calls and requiring a 2-hour response. So we have a locality offer, and then we have a 111 999 UCR offer. Since 8th of November, we've based ourselves in the 111 hub, and that's where it's made a huge difference, getting those patients that are currently not in our kind of system, and avoiding those kind of calls to 999 or admissions into hospital, or just referring back to GPs when actually maybe they could have done with that holistic assessment in order to prevent either further falls or further deterioration and that need for wraparound care from the community services. We're averaging per car around 4 to 7 patients a day. That's our aim. And we've got 4 cars currently going to be set up for the whole of Dorset, which obviously will link in with our ambulance services and the other falls teams. Next slide. Just a very quick case study. Actually seen a patient this morning that we actually got off the floor with a Raizer chair. They're phoning through 111. Patients remained on the floor at night time. Husband couldn't get her up. No care package, no local family, and had a pendant alarm. Patient on the floor on arrival. All the observations were completed. When we felt it was safe to lift the patient off the floor with the Raizer chair, we used that and then redid all the observations. The main things around that, there was no injuries, etc., but there was a risk of her having a chest infection, so we were able to prescribe antibiotics on scene, reviewed back by the GP or our locality teams, but also then that wraparound service, we were able to get the admission avoidance team from the intermediate care team locally to come and provide that kind of care and intervention and therapy input to see from a long-term point of view how they can cope at home and remain at home. So this lady stayed at home, having been medically reviewed, therapy reviewed, use of the Raizer chair to get her off the floor safely, antibiotics prescribed there. And actually that was about that early intervention, assisting her off the floor to reduce that long lie and reducing the patient being on the risk of being on a Cat 3 waiting list, waiting for the ambulance services that are obviously at full capacity at the moment. So this was a really good example of getting that patient really, really quickly and reducing that long lie and then that risk of being conveyed to hospital. Next slide. So again, summary events for benefits of UCR, like I keep repeating, it's reducing ED conveyances, particularly with our fallers and frail patients, the improving response time for the ambulance services, reducing time spent on the scene for the ambulance service as well, joint assessments on scene. It's reduced, the need to look at appropriate conveyances to ED, so we're actually choosing to admit, and also providing that information to convey that patient in with the social side of things, as well as equipment and environment, and a possible discharge plan as well. We're looking at kind of our community teams and how we can look at reducing that kind of silo working where we're all doing mission avoidance and falls prevention, but actually how can we bring our teams together, the joint recruitment, retention, education and training, shared learning, but mainly it's about improved quality care for patients. Next slide. Just a very quick one about falls. You know, nearly half our calls are due to falls. The UCR provide that holistic assessment and intervention, that kind of autonomous practitioner approach. So to be able to do the bloods, be able to provide medication equipment on scene and provide that community response wraparound care. And it's just to say that the Raizer chair has been absolutely essential, particularly this week. We've been in and out, and I shouldn't even be in the car at the moment. We were hoping going to be back at the office to do this presentation, but you know, we were called out to a patient on the floor. We used the Raizer chair. The patient was really happy and pleased with how it went. You know, she felt safe and secured. We reduced the long lie. She would have been on a Cat 3 waiting list for a long time due to the ambulance service being at such high demand at the moment. And you know, yes, she was conveyed to hospital, but she was kind of off the floor quickly and safely. very comfortable. And I think the thing about the Raizer chair is that it's easy to carry, it's portable, and actually one of the most essential pieces of equipment in our car alongside all our other things. And what we can do now is look at actually falls, so not just the UCR, but actually looking at our partners in third sector and the ambulance service to really highlight the need for how we manage our fallers. And I really like the fact that what Kathryn was saying about kind of the first response and having the falls team. So we have a bit of money on the side that we're going to pilot and test out a kind of a falls pickup service as such. We're not quite sure what we're going to call that, but it's going to be linked in very much with the UCR. So our services could be very much kind of for the fallers that have more medical need and need that more specialist care. And then hopefully kind of we can then sideline the kind of non-injury, low level kind of Cat 3 calls to the full service. And that's the end of the presentation.
Very good. That's excellent, Amy. Nice to well, both of you actually, really interesting, some of the things you've been sharing. And Amy is clearly back on her way back to the office. Now, the next step in this webinar, we wanted to kind of demonstrate the use of the Raizer chair in a scenario. Now, I totally get a lot of this is about providing that wraparound service. So 9 times out of 10, you may have that second person responding to that fall with you. But I was with Amy the other day and she had single-handedly responded to a fall, and just more to demonstrate the fact that with the Raizer chair being a very versatile piece of kit, it is able to be used single-handedly. So I'll demonstrate that with you. If I get my colleague Andrew to come on camera and have a fall for us. Just double check that he's on camera. Quite a graceful fall, admittedly, but trust you can see him there. So we're working on the assumption that I've obviously checked Andrew over for any signs of injury, and on the assumption that he is non-injured, we are then safe to lift. So for Andrew's sake, I may just keep him comfortable. Can't see too much right now. Is Andrew on screen? Can you see enough of him? Sam?
All good.
Okay, very good. So first thing we'll do is we'll just make sure Andrew's comfortable, maybe give him a pillow, and then using the Raizer chair, which obviously comes in the 2 packages. You've got the seat unit, and then you've got the back or the backpack, which can be carried around. So the only real movement that we need to get Andrew to do is to encourage him to bend his knees, like so. So Andrew's more than able to do that, provide some support if needed. We'll then push this chair underneath him, firm up against the thighs as possible, making it roughly central. And then actually in this backpack, got the lifting arms and also an instruction guide as to how to use it. So they'll come out in the order in which you need them. And we've got 2 completely identical backrests. So and we've got 4 of these lifting arms. So we just work round Mr. Webber. So if I can just ask you to cross your arms, like so. Then just maybe gently guide him away from the Raizer slightly, roll him off the backrest in. It will give us a little confirmation tone that it's in correctly. And then repeat the process around this side. Just roll away slightly. That's it. Very obliging fallen person right now. Okay. So it's probably worth noting that the seatbelt that I've just put on, mainly for reassurance, but can be slid up and down the backrest if more upper body support is to be needed. Then we've got these 4 lifting arms. If you can't put these in the wrong place, they simply won't fit. Work round. One more on this side. And then here. So you probably can't see, but there's the light is currently orange, which means it's not safe to lift. And I'll put this last one in. I'll get the light goes green and a slightly different noise to indicate that we're safe to lift. And around this side, there's a little remote control housed inside the seat unit. Simple up and down arrow. And then just by supporting Andrew's head as it comes up, I'll just press and hold. So as you can see, I don't think there is a second person helping me right now. Not that I'm aware of anyway. And we can just safely support Andrew up until he's comfortable. If at any point you obviously showed signs of deteriorating, there's nothing stopping us lowering him back down. If he was anxious or needed time to sort of get his bearings, you can stop at any point throughout the lift until he's ready to carry on, and then we'll complete the lift until he's in a full perching position. So once we get to the top, it will give us a little confirmation tone, like so. So that is Andrew from a fallen or lying on his back into a seated or perching position. I think that's good, Andrew. So that's the Raizer chair, kind of in principle. I appreciate I've covered it off briefly. This wasn't meant to be a product demo and guide as to how to use it, but it's just to get the principle out there that this can be used by a single person, and it is a streamlined piece of kit that isn't daunting or makes the fallen person anxious. Sam, over to you.
Thank you, Grant. So there is indeed some questions which we will field out, and I think Kathryn, you've probably indicated that you'd like to take the first one, which is a question: if they have access to UCR, should care homes continue to train staff to deal with non-injury falls and have patient lifting equipment in-house? So Kathryn, that's one for you.
So in simple answer, the answer is yes, care homes should continue to train staff. In my experience, some care homes, it's a common occurrence, a daily occurrence that someone's on the floor. And I think as Amy was saying, let's use the UCR teams when there's a medical, clinical injury type of fall. But if someone's just prone to legs giving way frequently, slipping down the chair onto the floor or whatever, yes, care home staff should continue to train staff and have the relevant lifting equipment available with the staff trained in how to use it. So that's my answer to that question. I know Natalie probably can't respond or speak, but feel free to carry on typing some questions in.
That's good. And Amy, I saw you nodding furiously at that point. Have you got anything to add on that question?
Yeah, absolutely. I completely agree. It's a simple, absolutely, yes, they should definitely have lifting equipment, Raizer chairs, and have the ability to have that trainer to be confident to, it's better to get patients off the floor safely and having the risk of a long lie and the risk of that conveyance in hospital. So I think there's a massive push needed to support care homes to have the confidence to be able to manage those fallers again off the floors.
Very good, very good. Okay, so we have another question which I am going to jump down to. What are the barriers to UCR teams being ready to deal with falls from early next year? So I don't know whether, Amy, do you want to take that one away?
Sorry, you can see that we're driving, we're just nearly having a little RTA there. So the question, can you repeat the question?
Sorry. What are the barriers to UCR teams being ready to deal with falls from early next year? So clearly that's not your team.
I think it's the demand, the capacity and demand level, which is why it's so important that we look at different ways of working together. Like Kathryn said, like I've said, I think there's the ambulance services and the UCR teams need to work hand in hand. I think that for us is that we've managed to get into the 111 hub and pull patients directly off the 111 list. I think that's a huge benefit, that instead of it being locality based, such that you're doing it from the 1 to the 9. So there's, like I said, there's two elements to UCR that we're trying to endorse in that, which is the 11999 UCR pathway, and then the local offer, which is your community teams, primary care networks, all working together at their local offer, as well as a kind of an at-scale model across the region.
If I can just add to that, in my experience, it's just they might not have thought of attending falls. They might not have the kit, and therefore the staff need to be trained in the kit, whether that's a Raizer or a Mango, whatever kit you're going to get. And I think there's a fear. There's well, it's paramedics that need to attend falls, and it's just that getting used to the fact that, you know, anybody can get someone off the floor with the right skills and training. So it's just about get going and focus. Like Amy said in her presentation, there's a lot of falls that really can be helped by and kept out of hospital, and especially getting there earlier, because the ambulance delays are just not good.
Very good, thanks both. There's a question from Trudy. Given that so many falls happen in the community, is there anything being done on a national level to support dom care agencies and community teams with falls response, so that UCR teams could focus on minor injury falls? I don't know, Kathryn, whether you've got any insight into that?
I mean, I think the question from Trudy is about dom care. There is a lot of stuff for care home support, but dom care, no, I've not heard of anything national. There is and community teams. So no, I'm not sure. There is a care home national team, and the probably is some dom care organised bit of NHS England, but I'm not aware of any specific work. It's about, some of it is about the assessment tools. I think people are very worried about getting someone off the floor, obviously, because they might be injured. So some of it is about basic first aid, which is, you know, if they can move their arms and legs and they're conscious and alert, they don't have a big bump on the head, no blood coming out. It's not rocket science. And I just think, you know, work with your ambulance service and talk to them about just what type of tools and checklists. You know, people often use the I Stumble tool that's out there. You can Google and find that, but find a tool, find an assessment tool, train your staff, and just encourage them to get the equipment and be quite confident in getting someone off the floor. If you start to move someone off the floor and they shout out in pain, then it's obvious, lay them down again. And then you can ring 111 or 999 if required, and or direct to UCR teams if you can develop those direct links.
Very good, thanks, Kathryn. One from Steve. Can the Raizer be stored outside? I'm just thinking about whether the community defib model could be replicated. So that's an interesting one. Just speaking from my perspective, I'm aware of some conversations with particularly one of the ambulance trusts in the south, who are interested in the prospect of a Raizer being stored outside in a location that could be accessed potentially by members of the public. But I don't know whether anyone else has got any thoughts. Kathryn, again, I might ask you on that one.
I think in an area where you've got, I think it's some sheltered housing, or, you know, you've got housing areas that have got predominance of older people, it's definitely worth exploring. It depends where, but yeah, there's no reason why, if you've got appropriately trained people, then the Raizer needs to be accessible. So I wouldn't argue with it, and it could be progressed.
Very good, thank you. A couple more questions here. One of them I'm going to address, I think, to Amy, and that is, what role do you see UCR teams playing in the hospital at home model?
Perfect fit, really, isn't it? It's providing that care completely. It needs to be working side by side. So the UCR model in Dorset is under the Asian Well programme and the Home First programme. So yeah, absolutely, it sits completely within that, providing exactly that hospital at home, and that treatment and assessment and that provision of care and that need for the reference teams. To keep our patients at home, particularly risk of infection, risk of delirium. Oh, sorry, my internet's going.
We got most of that, Amy.
Sorry. But yeah,
No
absolutely,
problem.
it should work side by side. It needs to work with the community teams, very much with them managing what patients they've got that have fallen and having that equipment, which I know our teams in the community do have access to the lifting equipment, but they can also call on us as well if there's a medical issue with that as well.
Very good. And we have a question from Julie, which I'm going to ask Grant. How many lifts do you get out of a charge on a Raizer lifting chair?
Amy will probably give us a better indication on that, but technically speaking, depending on the weight of the service user, you'd be comfortably should be able to get 80 on one charge. And on that, a charge of the Raizer chair seat unit, if you like, the battery takes about 6 hours. So once it's fully charged, it should be operational and able to be used countless times. Is that fair, Amy? You've got more on the ground experience.
Yeah, absolutely. We hardly ever charge it. So like I say, once it's fully charged, it's in the car pretty much a long period of time before we need to. But it's obviously got the ability to know kind of if it needs charging and that warning.
I think possibly what Amy was trying to say is that it has a battery indicator on the side of it that will tell you when it's getting low.
Very good.
Yes, I was, sorry. Southwest is good for reception here, clearly.
Thanks, Amy. Very good. Well, it looks like we've got through all of the questions, I believe, which is excellent. So any parting comments from Kathryn or Amy?
No, I think maybe share contact details. I've shared them with one of the people who asked a question, was asking how they can connect with an ambulance service, which I think was East Midlands. So I can help connect you if you need to talk to your ambulance service. Have a look at the Telecare Service Association around Telecare. Have a look at volunteers and community first responders. And, you know, knock on the door of the ambulance service if you're not already talking to them about UCR developments and falls.
Very good. Well, thank you very much, everyone, for joining. As mentioned, the recording and the resources will be shared to all attendees, and we'll make sure that contact details are as well. So thanks very much for the part that you're all playing in these rather unusual times we find ourselves in, and have a very good day.